Hello everyone, my name is Guilherme Tizani. I'm the director of the Structural Heart and Valve Center at University Hospitals of Cleveland. I'm going to present today my highest successful aortic implant. These are my disclosures. We're going to discuss today a 79-year-old female with a recent diagnosis of invasive ductal carcinoma of the right breast. She had a GI bleed in 2014 and also a hip replacement and a prior hysterectomy. She was on her workup for her breast surgery. They identified a murmur, and she was actually complaining of worsening dyspnea and exertion fatigue. When they did an echo, they observed severe aortic stenosis. As you can see, the parameters there with an aortic valve area of 0.35, mean gradient of 90 with a DI of 0.11. This is her EKG, quite remarkable. The aortic valve, as you can see here, the excursion of the leaflets is very limited. When you look at the short axis, that appears to be a bicuspid valve. And the parameters of the echo here, as we discussed, so very clear severe aortic stenosis. Heart catheterization showing normal coronary arteries there. RCA normal as well. Here we come to the CT. So as you can see here, her area of 532 and perimeter of 84. This is annular, obviously, and the STJ of 29.5. Then when we look at the sinus of Valsalva, all of the sinuses are above 30, and you can see that there is a fusion between the non and the right coronary cusp there with the calcified raphe. And when we measure the perimeter of the commissure, we have a perimeter of 75. Then coronary heights, 14.7 for the left, 12.4 for the right coronary. Then the discussion that remains here, this is actually a debate that is an ongoing debate, is what's going to be the valve we're going to use. If we pay attention to the perimeter of the annulus, she would be a candidate for a 34 evolute valve, whereas if we size this patient in the perimeter of the commissure, she would be a candidate for a 29 evolute valve. As we know, the sealing mechanism is going to happen in patients with bicuspid valve. That's going to happen in the commissure. So it makes sense to size based on the commissure. However, the sizing based on the commissure has potential flaws, and one of them is the reproducibility of the measurement, that it's not as reproducible as it is when we size based on the annulus. Therefore, the formal recommendation today is to size based on the perimeter of the annulus. However, we size our valves, bicuspid valves, whenever there is calcium in the raphe. We size our valves based in the perimeter of the commissure, because that's where the sealing happens, and we have been very comfortable with that. In this case, again, it's interesting because if we size based on the perimeter of the commissure, it's going to be a 29 valve. If we size based on the perimeter of the annulus, it's going to be a 34 valve. So let's see what we did. Well, the case summary, those are the measurements, and as I mentioned, we would have picked 34 based on the perimeter of the annulus and a 29 based on the perimeter of the commissure. We decided to go with a commissure perimeter, therefore we picked a 29 valve. Obviously, this is a case for pre-dilatation, as we do for every bicuspid valve. And when we're dealing with bicuspid valves, because the sealing happens in the commissure, we tend to implant the valves even shallower than we do for tricuspid valves. So I usually aim at 0 for my tricuspid valves, right? And when I'm dealing with bicuspid valves, I'm going to aim shallower and more aortic for obvious reasons, because the sealing is going to happen in the commissure. Therefore, I have to aim at that level. So let's see what happened in this case. So we pre-dilated this patient with a true dilatation balloon. As you can see, you can see the calcium moving there. And then we went with a 29 valve. So if you pay attention to this, to the picture that we took when we were at 80%, right? When you look at the pigtail that is sitting in the bottom of the non-coronary cusp, you can see that the valve is significantly above the pigtail, right? And it's hard to even quantify that. You can tell -5, -6. It's really a negative position. You can see that we are like +1 or 2 on the left, but definitely we are very aortic in the non-coronary cusp. Well, one thing that draws our attention in this picture, in fact, I did this case live, and I asked the panel if I should deploy or recapture the valve. The vast majority of the panel said you have to recapture, and I said, well, I'm going to respectfully disagree with the panel and deploy. And the reason for that is because I trust that the sealing happens in the commissure, which is true. And when you look at this picture, one important information that we can see on this picture is the fact that there's no AI, right? The valve is 80% deployed, not even fully deployed, and there's no AI. Even if there was AI, I would still have deployed confidently this valve because I know that the sealing is going to happen in the commissure. When I saw that there was no AI, I was basically happy with that and decided to deploy the valve. Well, what is an echo with great results. So you don't see any paravalvular leak in the long axis of the aortic valve. And same story for the short axis, looks great. I want you to pay attention to the fact that we can see sort of a D-shaped valve there, which is very common to see on patients with bicuspid valve. However, I want to emphasize the fact that because this is a supraannular device, right? Although you see a D shape of the metallic structure there, but the actual leaflets are functioning above that level, and therefore the coaptation is going to be optimal because we're decoupling the actual the catheter-based valve, the actual leaflets from the annulus here. This is the 5 and the 3 chamber views. They look great as well. We don't see any paravalvular leak. And the rest of the story, this patient was discharged home next day on aspirin and Plavix. She had no conduction disturbances. 1 week follow-up. She was in NYJ class 1, and she underwent breast surgery a month later. So this is, I think, a great example of a very, very shallow implantation that we had a very successful result. Thank you for your attention.